Hello, all you healthcare professionals. My name is Alex Hughes. I am a nurse practitioner out here in Austin, Texas. I work directly under the supervision of Dr. Kaushik Shah at the Austin Urology Institute. I am the lead nurse practitioner out here, and I have been doing it for about 7 years. So urology is my name of the game, and I absolutely love it and love men's health. So this is my webinar on consulting patients for aquablation therapy for healthcare professionals. I am a PROCEPT biorobotics consultant, so here's my disclosure. This is my credentials. Again, I am the lead nurse practitioner. I've worked my way up through the ranks. I do hire and train new nurse practitioners and PAs on diagnostic cystoscopies and transrectal ultrasounds, cystostent pools, and all the procedures that we do love. I have a master's from Spring Arbor University. My bachelor's was from Texas Tech University. And then here are the responsibilities at the clinic. You can see them down below. So my main objective here is to really get the word out to surgeons, nurse practitioner, PAs, and any healthcare professionals on why it's really important to de-prescribe BPH medications and get men into an effective, durable treatment that preserves their long-term health. So basically, getting away from this, hey, medications, hey, this is the only thing we can do, hey, here's your tamsulosin, and kind of see you in a year. That approach to me seems to have had more injuries to my patients than helped them, and I'll kind of walk you through why I think that way. So why do I say get patients off medication? So alpha blockers, these are your tamsulosin, your alfuzosin. A lot of times my patients and practitioners alike have learned that these are just benign medications, when in fact they aren't. So the big risk are orthostatic hypotension. It can also worsen heart failure, retrograde ejaculation. So the stuff you shoot out, if you know what I mean, goes away. So it goes into the bladder, which is one of the number one reasons my patients don't actually keep going on the medications. But the big scary one is the orthostatic hypotension. So most of BPH patients are older patients, right? 60 and above. And whenever you get up out of a chair, get up out of bed, you have this little woozy feeling. That's orthostatic hypotension. So these alpha blockers can worsen that. So the last thing you want to do is have a 76-year-old, like my example I have here, that I prescribed alfuzosin or tamsulosin. I can't remember which one. He had an IPSS score of about 17. And I did the right thing as a practitioner. I said, let's give it a medication trial. And unfortunately, I had a call from the ER the next night from my patient, or actually from the ER doctor, that my patient had gotten up in the middle of the night to go pee, part of his routine, and he had an orthostatic syncope episode, fell down, hit his head on the toilet, ended up with about 17 staples across his head. So thank God that patient was not on blood thinners, or else we'd be singing a different tune. He ended up being fine, and I ended up treating it with some surgical procedure. I think it was aquablation, and he did very, very well afterwards. But these thought processes that medications are just benign, let's just take them, especially when they can interact with other medications, and especially the next medicines I'm about to talk about, is just wrong medicine in my opinion. 5-alpha reductase is your finasteride. So the biggest side effects are erectile dysfunction, decreased libido, and ejaculatory disorders. They've recently come back within the last 5 years talking about potentially earlier cognitive decline, mood swings, mental fog, and then the prostate cancer. So one thing that a lot of patients and practitioners don't realize, that when you're on full dose of finasteride, it actually shrinks the prostate. But what it doesn't do is shrink prostate cancer. So if you happen to have some prostate cancer that's elevating your PSAs that are in the 4s, 5s, 6 range, and you're on finasteride, that'll actually decrease your PSA underneath a threshold that actually hides the prostate cancer. So I'm seeing younger and younger patients come to me with sexual side effects. I'm talking 20 to 30-year-olds, and they're getting a lot of these products from Hims and Hers, these online pharmacies. So finasteride is also for hair loss. So what patients don't realize is how the medication works. So when it knocks down your DHT receptors, you can have these unwanted sexual side effects. A real life example, I had a patient that needed to have a PSA clearance. So a lot of times we partner with other practices out here that offer like testosterone and things like that. And some of their protocols will not allow their patients to receive testosterone if their PSA is above 3. I inherited the patient and realized that the patient had been on, Hymns with full dose of finasteride, and his PSA was not 3, it was actually a 6. And when I did a prostate MRI, I did find a lesion. We ended up biopsying him, and he ended up being okay. We did a prostatectomy on him. So these medications do have harmful side effects. So whenever patients just say, I'll just take the pill, this is how I kind of talk to them and say, hey, it's not just taking a pill. It's also taking a pill 365 days out of the year that being filtered through your liver and kidneys. So why not do a procedure that has little to no side effects and that can get you off of these medications for a long period of time? This is Aquablation's video. Hopefully it'll play here and you can hear it.
The Hydros robotic system is the next-generation AI-powered robotic platform that delivers aquablation therapy for benign prostatic hyperplasia. This clinically proven therapy uses real-time ultrasound guidance combined with cystoscopy to provide surgeons with a full, detailed view of the anatomy. Developed from a library of real-world aquablation therapy procedures, First Assist AI identifies critical anatomy on ultrasound to aid the surgeon in designing a patient-specific treatment plan. Through robotic control, the heat-free water jet precisely follows the treatment plan. During every procedure, prostate tissue is accurately removed in an efficient and predictable timeframe. The streamlined workflow begins with the insertion of an ultrasound probe, providing the surgeon with a full view of the prostate. The single-use handpiece with integrated cystoscopy allows the surgeon to visualize the anatomy as it is inserted, positioned into the bladder, and docked to the articulating arm. Once the entire prostate is visualized, the surgeon initiates treatment planning. Treatment planning begins by identifying critical anatomy using First Assist AI to develop a plan specific to each patient. Adjustments to the plan can be made to the resection angles and depths under real-time ultrasound. The Verumontanum protection zone is created to help protect sexual function. Robotic-assisted resection removes the desired tissue and avoids the verumontanum by using a bilateral cut to help preserve ejaculatory function. The surgeon maintains control of the resection throughout the entire procedure. Once water jet resection is complete, the surgeon performs focal bladder neck cautery using a resectoscope to cauterize exposed blood vessels at the bladder neck. The Hydros robotic system is the next-generation AI-powered robotic platform for aquablation therapy, a clinically proven procedure that provides significant durable symptom relief while preserving sexual function and continence across prostates of all shapes and sizes.
So that's aquablation therapy. It has been a game changer for our patients out here in Austin, Texas. We really dove headfirst into aquablation in 2023, and we've had a giant success with our enlarged prostate glands for our patients. This is a very data-driven, heavy page. I won't go over it for a long period of time, but I will say that the data that I have pulled on all my patients line up with exactly the data that PROCEPT and Aquablation has put forth for this presentation. So basically, this is 10-year data. It's all water 1, water 2, Francois water, and open water. The middle paragraphs basically say it was across the globe, thousands of patients, all different sizes of prostate glands, and with median lobes. So the 4 bottom categories are what line up with my patients so much, and that's what I really want to harp on terms of how successful it's been for our patients. So the efficacy. So the IPSS score, this is your International Prostate Symptom Score. It's a 0 to 35 scoring system. We are having patients all the way into the late 20s, so high 20s, 25s, 26, 27, 28s, even into the 30s. And after treatment, their IPSS score is dropping into the 5, 6, and 7 ranges. And that fits exactly what their data is showing. So giant improvement on the IPSS score. Medications alone, most of the time you're getting about 6 to 8 point reduction from medications alone, and you have all the unwanted side effects. Safety, so the safety of the actual procedure. Our current rates right now, we are actually doing same-day discharge in about 90% of our patients. 10% may stay overnight due to any kind of complications or bleeding during the surgery, but 90% are same-day discharges. Functional. This is why patients choose aquablation therapy. Ejaculatory dysfunction has a huge decrease in the amount of people that are actually having ejaculatory dysfunction. So because of that butterfly cut at the end, it misses the foramen montana, which actually houses or actually produces the ejaculatory function portion of it. So because it has this wide angle cut, people are not losing their ejaculate. So the stuff that comes out, right? Erectile dysfunction, I can speak to this wholeheartedly. I have yet to have a patient that has complained of ED post-operatively. Now, I will say complained of it, and we do ask, but I have not had anybody. And then the most important, stress urinary incontinence. Patients aren't leaking urine after this procedure. You know, I will talk to them about these three portions of, the functionality of this. And the most important is you don't want to be wearing diapers after a BPH procedure. And none of my patients are leaking as of yet. Yeah. And we've been asking very hard questions about that. Durability. This is 5-year data. So basically what this is saying is every year out, you have a 0.5% retreatment rate where you verse it all against all of the other resection procedures out there. This is the lowest in terms of resection rate. They are about to release even newer data that is going to show how long this is looking at. What I feel like this is about a 10 to 12 year. And then the newest data is actually showing that it may be even up to 15 years, but we're waiting for all those results to come out. So optimizing BPH care with a team-centered approach. This is the most important. So I am a nurse practitioner, right? I am not the surgeon. But I am signing up all of my patients, doing the diagnostic workups, reviewing the urocuff and urodynamics, and making sure these patients are appropriate for surgery. So the thing that I'm trying to speak to all of my colleagues out there is to utilize your nurse practitioners and your PAs. We are much more capable than what we've actually been trained on, or how it's historically been looked at, I guess I should say. So why we had to reevaluate our workflow. So we had a rising patient demand requires greater efficiency. So basically we were getting busier. Right now I have 2 doctors that I sign up my surgeries for. I've had 3 in my career. So Dr. Koshik Shaw and Dr. John Monterello. So we have 2 doctors, and we have this huge influx of patients. So, whenever they're operating, they can't be doing diagnostics. They can't be spending a lot of times with these patients and doing these intense BPH care pathway discussions. So he asked me, he was like, so how involved do you want to be in the practice? And I am a proceduralist at heart. I was a firefighter paramedic in the very beginning. I was an ICU nurse for a while, between then and ER, kind of floating around. So I absolutely love procedures. So he asked me, he's like, would you want to do something like this? And of course my hand was up in the air, like, yeah, sign me up, Buttercup. So before this, we were having a 6 to 8 week wait time to get in with Dr. Shaw. That's as a new patient. And then when he decided, all right, well, we need to do a diagnostic cystotrust and potentially a urocuff to see what this is, it's another 4-week wait. So by the time we were actually doing surgery on these patients, it had been about 3 months or so. So when he utilized me, and now I am teaching all of my other nurse practitioners and PAs, I am getting these patients surgery much faster. I will see a patient, maybe a new patient, on a Monday. I will cystotrust them on a Tuesday like today. Wednesday, tomorrow is a urocuff day. Telemedicine, I'll picture everything together and put it all together and submit it to insurance and make sure they're appropriate for surgeries. That's the biggest thing, is we don't want to sign somebody up for something that they actually don't need. So I utilize all of my equipment, all of my tools to make sure they're appropriate. And yes, I was motivated to play a bigger role in patient care. It is much more satisfactory to me. And it's also just, it's kind of my egg on the face if my patients don't do well. And luckily with aquablation therapy, we have not been having those issues. All of my patients, if not every one of them, I'd say maybe 2 or 3 had maybe some complications post-operatively that required maybe another resection at 1 week or so. But we've done this to around 225 patients up to date, and the vast majority are doing extremely well after their procedure. So we built trust. So how did we get to this phase of our career, me and Dr. Shaw? So basically, I kind of joke that I'm aging myself here, but if y'all have seen the movie Ghost, where Demi Moore is, molding the clay, and then, the ghost comes around and kind of teaches her to do it. That's how I learned cystoscopy. At one point, Dr. Shaw would bring me into the room. He would show me how to do it. I would watch him, and then he would say, all right, your turn to drive the car, and I would get in and I would start doing it, and I would flounder a little bit. He'd come around my shoulders, but back it up, kind of place the catheter, replace the cystoscope in the right area, and then the transrectal ultrasound, I would do the measurements, and he'd be like, hey, this is a little different, but it was a very team approach. But the investment he gave into me has paid off immensely further down into his career, because now he's not invested in me, teaching these other nurse practitioners and PAs. I've gotten so good at it and had enough clients behind my belt that I have a good skill set so where I can teach these other nurse practitioners. It was about a 6-month whole kind of program where he would do them. He'd pull me in. We would do cystostent pulls, those kinds of things. He would watch me, and I'd say I probably did 20 of them, watching him, then did 20 with him with me, and then I was released to do on my own. We took pictures, so cystos were recorded. We use Athena EMR as our EMR. So there's something called Athena capture, so where I could actually take pictures of like a big median lobe, or, God forbid I see a bladder lesion. I would take pictures of the actual kissing lobes, and I would take pictures of the transrectal ultrasound, and it's all populated right there in the chart. And I would review all these charts with him. Patient education benefited from observing the procedure 100%. So when we started doing aquablation, Dr. Shaw was nice enough to close down my clinic. If it was a slow day, he'd be like, hey, come in here and come see the OR case. So one thing that I will say as my MPs and PAs, get in there and see an aquablation. It is so important to be able to see how the sausage is made for you to speak to your patients about it. Clear BPH pathway enables me to manage patient selection and work up consistently. My BPH care pathway did not come overnight. This was about 2 years of trial and error, but at least I can share this with you and see what works for my practice, and hopefully it'll work for yours. Patient workup and consulting. So this is my BPH care plan pathway. Okay, so this is pretty easy to follow. So anyone that's male patient that's above 50 years old, or with any urinary complaints or on any BPH medications, they fall into this care pathway. So if they're any of those 3 categories, we're going to perform an IPSS score, so International Prostate Symptom Score from 0 to 35, a PVR, which is a post-void residual, so whenever you urinate, your bladder is supposed to be empty. If you have bladder dysfunction due to a prostate obstruction, you're going to have higher PVRs. A UA, so a urinalysis, we want to rule out any kind of infectious material, and then a DRE. Dr. Shaw's practice is still, if anyone's 50 years above or older, they still get a digital rectal exam. So once we do that, if they're referred over to me and if they're on medications, I'm going to discuss the side effects of medications. I am going to do my best to tell them and say, hey, we need to go and work you up and look with a cystoscopy and transrectal ultrasound. That's twofold, right? So then we go and look at the bladder health, and we also can make sure that they're on the right medications. So if they're on meds like tamsulosin, alfuzosin, finasteride, I'm going to talk to them about the side effects. If their IPSS score is sub 10, okay, I'm going to take them off of their medications. I'm going to wean them off for 30 days and repeat the IPSS score. I have found a lot of patients that have been incorrectly treated for BPH obstruction when they've just had overactive bladder. So if they've been on tamsulosin and I stop it for 30 days and I bring them back and their IPSS score doesn't change, I'm like, okay, maybe we were barking up the wrong tree. Let's start looking at the bladder. If their IPSS increases, right, so they become more symptomatic, I know that it's BPH, so then I start talking to them about cystoscopy and transrectal ultrasound and a urocuff. So if they're not on meds, I do the right thing. I will talk to them about medications and the side effects of medications, and I will trial them on meds. So we'll do a 30-day trial of mainly alfuzosin is the one that we usually choose, but tamsulosin is also there. And we'll, if their IPSS score is nice and high and 15, 18, 20, 25, 35, and I trial them on meds, and that brings their IPSS score down by 6, 7, 8 points, because that's typically what medications will do, is they'll drop it by that little. Then I know it's BPH. And then I talk to them. I'm like, all right, we're on the right symptom tree. Let's do the cystoscopy, the transrectal ultrasound, and the urocuff. Let's figure out a procedure so that you don't have to take a pill for the rest of your life. All right, I've mentioned urocuff. So urocuff, The way I describe it to my patients is we had a freeze out here in Austin, Texas, where our pipe burst, and so we had to call a plumber out there. The first thing the plumber did is go out to our outside bib and put a pressure gauge on it to see what the internal pressures of our house are to make sure there's no leaks. So the UroCup is a way of checking the internal pressures of the bladder. So what we deem necessary for aquablation therapy is anyone that has 15 mils per second or less. So it also has a urodynamic component, so you have abdominal voiding that it can pick up on. So it's a very really good test that is done in the office. There's also something called ProudP, which is an app that uses audio from your phone that you actually can download. And you can actually listen and get a uroflow measurement from that. So either one, so I see satellite patients that are, outside of Austin, like 30 to 45 minutes outside, and they don't want to drive here all the way for a urine test. So that could be a good option for those patients. So we couple all of that together, and then I have either a telemedicine visit or an in-person visit, and I talk to them about it. So this is our, our surgical approach, right? So 30 grams or less, they are a UroLift or a Zoom. So it's called a MIST, right? So minimally invasive surgical techniques. These are our office procedures. And when I talk to them about UroLift and I talk to them about Resume, UroLift is actually a bigger component of our practice. We haven't done a lot of Resume, so I'll talk more about UroLift. UroLift is extremely good for smaller prostate glands. So like when I talk about UroLift, I'll put a piece of paper on the wall and I'll staple it to the wall, and I'll say, if I staple this piece of paper to the wall and I leave it there, unless somebody comes and rips it down, it'll probably stay there for forever. If I have 60 pieces of paper there and I use the same kind of staple, it's not going to hold as long. So the more mass of your prostate, the less successful the BPH procedure is for UroLift. So 30 grams or less, we do UroLifts. 30 to 50 grams, kind of anything is on the table. And I approach it that way. I tell my patients, I'm like, all right, here are your options. This is probably what I would lean towards, but these are your options. So 30 to 50 gram glands, you could do an in-office UroLift or in an OR setting UroLift or an Aquablation or a TURP, okay? 50 grams or above, it's either an Aquablation or a TURP. So 50 grams and above, especially with the trabeculations of the bladder, which I'll talk about in another slide, you really see from resection procedures the biggest success. Whatever procedure they end up choosing, we'll have a cath removal post-op day 1. About 90% of our patients, sometimes if there's a little bit more blood in the bag, we'll have the catheter in for about 2 to 3 days. So typically we have surgeries on Tuesdays, cath removals either Wednesday, Thursday, Friday, based on what's kind of going on with your urination status. You'll stop your BPH medicines 2 to 4 weeks after that. So if you have like 22 pills of alfuzosin, I'll just say just finish out your prescription and then just stop. So we don't want you to stay on your medicines. The whole point of us doing this procedure is to get you off of the medicines. After 90 days, we're going to do a repeat UroCuff or ProudP. So I want to see how much I've helped your urine flow, right? So the UroCuff looks at pressure and flow rate. So if you have, 7 mils per second at, 150, millimercuries of pressure, if that decreases to a, 80 and then a flow rate of 25, then your increase of your flow, we removed the obstruction. We've done what we needed to do to help you urinate better. National average to conversion rate. So what this is saying is BPH patients, in the U.S., so nationally, 1 to 3% move forward with surgery. I've pulled all of my data here at Austin Urology Institute, and my conversion rate of patients is about 50%. So we're doing something right in terms of getting these patients treated. Workup tools, so these are basic to advanced. So this is what every practice should utilize. I get shocked whenever I see or I inherit patients from other practices that have never had an IPSS score. They've never had a bladder ultrasound. So this is standard for us. So an IPSS score, it's a numerical score from 0 to 35. Bladder ultrasound, checking for those higher PVRs, post-void residuals, bladder dysfunction, urinalysis, and DREs. Those are simple, they're easy to do, they're inexpensive for your practice, and it gives you a load of data. So this is a data-heavy page, and I won't go over it a ton, but what this is showing you is what the IPSS score can calculate to other kind of symptoms. So quality of life, PVR we've talked about. Qmax, this would be on your Urocuff or Proud P. Urodynamics, cystoscopy, and treatment. So that green column on the far left, basically that's a patient that's not having symptoms. So a lot of times I'll have a 55-year-old coming in for like kidney stones and I give them an IPSS score and they have all zeros. I'm not going to make them do a PVR and an a UA and DRE. Oh, he will get a DRE because he's 55. But y'all get what I'm saying. If they're not having symptoms, I'm not going to put them through the rigmarole. If same guy, if he's 55 and coming in for kidney stones and we give him the IPSS and he scores a 15, then he's having moderate symptoms. I can almost expect on that bottom of that IPSS score, his quality of life is going to be 3 to 4. His PVRs may be up to 100. The Qmax may be 10 to 15. So 15 and below, there is pretty significant obstruction. High pressure, high flow on the urodynamics. Cystoscopy will show moderate trabeculations. Treatment, medications versus procedures. I don't love that because I don't like medicine. So I would say procedure, even on the moderate, severe, and critical, would all help these much better than medications. But you can kind of see what the IPSS score and what it accounts to. Now, I will have patients that also have IPSS scores of a 9, but their PVR is 500. So, I mean, this is not exact, and that's why you have to use all of your data in your office to come up with a good treatment plan to make a good choice for the right patient. Okay, so I am a analogy-heavy person. So this is how I educate with my patients in terms of analogy. So my mechanic analogy. So this is like a brand new patient that comes to me and has an IPSS score of a 20, and they're like, what should I do? And I'm like, okay, if you had a car and it was rustling around in your engine and you took it to a mechanic and the mechanic's like, man, I've seen this 1,000 times. Just try this new synthetic oil. That's me trying medicines on you. I don't know what's going on in the engine. I'm just going to try this out, and if it works, great, and if it doesn't work, whatever. So what you really want your mechanic to do is get under that hood and find out what's rustling around in that engine, and that's how I introduce cystoscopy and transrectal ultrasound. So if you want the mechanic to get in and fix the problem, you need to kind of go in and look at the problem, and that's where cystoscopy comes into play. So retention. So this is a guy that comes in that I put a bladder ultrasound on him and his PVR is like 300 and he goes and urinates and then it's down to 280. And he's like, okay, well, it went down. I'm like, dude, your toilet is clogged. What happens when you have a clogged toilet and you flush that toilet? Where does the water go? The water goes out of the toilet. So where does the urine go? It goes up into the kidneys. When you have a clogged toilet and it's not flushing appropriately, the excrement and stuff will sit in that toilet bowl. So that's why patients that have high PVRs have urinary tract infections. That's why they have bladder stones. Their bladder is not emptying. So it sits there and muddles around and causes really big problems. So you need to get in there and you got to remove the clog. Me trying medications for this patient's me like putting Drano down the toilet. Y'all probably all used Drano before, and Big Drano is going to be mad at me, but it removes what? 30% of the clog. It doesn't do it. What you got to do is plunge it or get a plumber out there and snake the toilet, and that's whenever I call my plumber Dr. Shaw. Rings of a tree. This is when I'm doing my cystoscopies. So whenever I'm doing these cystoscopies, they're here in the office, and I'm actually doing the cystoscopy, and I'm showing the patient. So the patients are awake for this, and it's, you know, kind of a good, bad thing here. I'm like, the good thing is you're awake for it. The bad thing is you're awake for it. But I like to show my patients all of the images because it makes a big impact when I'm doing my consults. So when I'm doing the cystoscopy and I see the severe trabeculation of the bladder, right? So this is how I talk about the rings of the tree. So the more severely trabeculated the bladder, the more rings of the tree are. So when you cut a tree in half, you can count the rings. I think they still do that. And they can say how old the tree is. That's how long you've been suffering through BPH. So the more severely trabeculated your bladder is, the longer you've been suffering and the more bladder damage you've been having. Cleanup batter. So this is how I finish out my entire consult. I tell them I make $0 whatever decision they make. The only satisfaction I get is that my patients are doing well. So that's why I've been pushing Aquablation therapy so hard, because my patients have been doing well. And also, I got to tell you, my on-call we cover call for our patients. So like if they page after hours and they're having complications post-surgery, we get the calls, we as the nurse practitioners and the PAs. After we've started doing Aqua, we have our call volume has gone down to next to nothing. So patients are doing extremely well. They're not hurting, and that call volume has been much decreased with us. We have to undo generations of fear of today's BPH treatment is not your grandfather's. I guarantee you, if you're a surgeon or a urologist or a nurse practitioner and PA that's in urology, how many times have you had a guy come in and be like, I ain't doing that, man. My buddy Mark had that done and, his fingernails fall off. I don't know. They say all sorts of stuff. But then I started asking them, like, well, what surgery did you have done? He's like, I don't know, but it was something to the prostate. I'm like, okay, man. We've microwaved the prostate, we've froze the prostate, we've taken it out completely, we've heated it, we've stuck barbs into it, now we've water pressured it. So there's a lot of different kinds of things that can be done to the prostate. Most patients don't know about aquablation therapy, so it's our job to teach them about the newest technology out there. So these are some cystoscopies that I performed. So the regular bladder tissue is supposed to look like the bottom of your hand, okay? So it's very smooth, no wrinkles. So when I do a cystoscopy on a patient and I show them these pictures and then I show them a healthy bladder, it's very, very apparent that they're like, okay, I have a problem. So on this far left one, this was actually a patient that I inherited that had been on dual therapy, like tamsulosin and finasteride, for 20 years. They came to me and their urologist retired and they needed a new urology urology practice to follow them. So I get him, and he was just wanting to have his medications renewed. And, he fit into our category, so we did our workup, and his PVR was like 300. And I'm like, when's the last time you had a cystoscopy and a transrectal ultrasound? He was like, I don't think I ever had one. And I was like, all right, let's get in there and take a look at this organ system. So that was his cystoscopy. It looks like a big spider web, trabeculated bladder. This is what I would call the grade 3 trabeculation. He had been suffering for BPH for so long and only thought dual therapy was the only option for him. It was unfortunate. So this guy was making bladder stones. He was having chronic urinary tract infections. After we did aqua, his bladder will not ever go back to normal. That's one thing that I always tell my patients is we can open it up as best as possible. We can decrease that pressure, but the bladder kind of damage is done, but you don't want to make it worse because the end stage of BPH where you have this kind of severely trabeculated bladder and high PVRs, it's putting catheters inside your bladder so that you urinate. So that's why you want to be scoping early. You want to catch this early because the medications do not do justice compared to what a procedure can be done. This middle one is like a grade 2 trabeculation. You can really compare those two. And that's the kind of patient I'd be like, all right, I can start to see this bladder starting to get damaged. We really need to do something here to decrease the pressure so that you don't end up with grade 3 trabeculation and have all these side effects. This third one is a big juicy median lobe. So this was a patient that I inherited that had been on a singularity therapy with alpha blockers and had never gotten better. And, he was from an out state of urology that had never done a cystoscopy on him. And he was like, I've been on these medicines for years and they just don't feel like they're working. So I get in there and I scope them and of course they're not working. That big median lobe is sitting over the bladder outlet. You can kind of see the camera hiding back there. So that's my camera looking back on itself. That giant softball median lobe is not going to be affected by any kind of medications. So that's why he wasn't getting any better on the medicines is they were treating the wrong thing. So you got to get in there and scope. So how I consult, I talk about TURP. So TURP is transurethral resection of the prostate. It's still gold standard. It is still one of the most preferred methods by urologists, and it was invented in the late 1920s. So why are we using 100-year-old technology when we could be utilizing the stuff that's out there that's new and that's doing better for our patients? Missed glands, so that's your resumes and urolifts, small glands, aquablation therapy, been beautiful for my patients. So this is how I consult on them. Those little wall boards are in all of our clinics, and it has a little sliding scale. It's where I can show them what BPH is. The main one I wanted y'all to focus on is the one where I drew on it, right? Y'all can see where I actually drew the trabeculations of the bladder. I drew the PVR, so the urine left over in the bladder. If they have a big median lobe, I'll draw it in there. If they have a bladder stone, I'll draw it in there. If they have a big bladder tumor, I'll draw it in there. But then I can show them why they're having these issues. It's very enlightening whenever I tell patients, you know why you're getting up in the middle of the night, why you're having nocturia? It's because you have a PVR of 150. Whenever you go to the bathroom, you think you're empty, you go lay down, sloshing around this 150 cc's, and your brain wakes you up, says, go pee. You go pee, leave 150 over, go back to sleep, slosh around, gets you up again. So you've got to empty the bladder. So those blue little squiggly lines are me showing how aquablation works. And then that's our trifold that we'll also use for our patients. So what's recovery like? Potential overnight stay, 90% are going home same day, 1 to 2 days on a catheter, typically done on a Tuesday, catheter out before the weekend, avoid strenuous activities for a week. How soon will symptoms improve? 2 weeks to 3 months, may pass blood clots and scabs over about 3-month period. I will say my biggest complaint from patients is some intermittent dysuria. So like sometimes the urine will hurt, and it's basically from the actual prostatic tissue sloughing off microscopically and can cause some dysuria. Some patients say that it lasts for about a month or so. Some patients say they don't notice it at all. And I would say most of them are saying that they don't notice it at all. Well, I keep sexual function. Again, I talked about it earlier on in the webinar. Most of my patients did not have any ejaculatory dysfunction, no ED, and nobody is leaking any urine. Well, I need another surgery date at a later date. Yes, prostate glands always grow. Unless you take out the entire gland, you're on the risk of needing another surgery. Less than 3 to 5 years based on office-based procedures. So basically what this is saying is it's a resection procedure. So you're removing the meat of the prostate. You're leaving all of the shell on the outside of it. So just think about that portion of it. The prostate will grow. That's the nature of the beast. So if the prostate grows and it causes an obstruction 10 years out from the procedure, then yes, we will have to do another one. Can I stop taking meds for 1 month, stay on the alpha blockers, then 4 weeks meds will stop, goes stop meds altogether, get off the medicines. Catheter, similar to a cast. So like when I talk about a catheter, whenever you have your prostatic orifice that's been treated right here and the catheter is inside your bladder, it's keeping that area open and healing properly. So last thing you want is that tissue to kind of stricture down. So that's what the catheter is. Again, compared to most of all the resection procedures, it's a less amount of time. And most of our patients are only having it for 1 to 2 days. Post-op expectations and experience, hematuria scale. So we have been very, very lucky in terms of post-operative care. I have not had a lot of heavy bleeders from my post-op patients. I think it's probably due to my surgeon's techniques, but most of our patients, when we pull the catheter, are grade 1s, 2s, and 3s. If they are grade 4s and 5s, we'll leave the catheter in, have them increase water, maybe decrease some activity to try to clear that up. But we usually pull catheters 3s, 2s, and 1s. Merlot is that thick blood. That's where we would actually have them increase water, keep the catheter in. Pink and rosé, rose to lemon, lime, Gatorade is perfectly fine to take out. A thimble full of blood into the bladder will turn the entire urination dark red. So it's much more visually scary to see than what it actually is going on. And then we have a patient portal. So we use Athena, so my patients can actually send in any kind of pictures they want. So a lot of times I'll have pictures of catheter bags and like, oh my gosh, is this clot normal? Is this blood normal? I'm like, yes, it's very normal as long as the catheter bag is draining and you're not having abdominal pain, you're good. So this is our post-op patient materials. I created this with the help of our surgery schedulers. So we give this to all of our aquablation patients, and it goes over the post-op expectations, the potential medications, care instructions, and timeline. It's a very good reference for someone to have an actual physical copy or a printed copy and they're saved on their computer to reference to. But I go over everything. Impact of our approach. So patient impact, post-op outcomes led to expansion. So basically we started aquablation with smaller glands like 40, 50, 60 gram glands. And as they've been doing better and better, we pushed it all the way up into 150 gram gland sizes. So we've gotten so comfortable with the procedure and our procedures have been doing so well, we've pushed the gland size up as much as it can go. Surgeon impact built confidence in same-day discharge, furthering operational efficiencies and patient experience. So this was our 2024 data, so 136 procedures. You can see we did gland sizes all the way up to about 150 gram glands, all the way down to around 20. So this is my most proud slide because I pulled all of this data. So this is our 2024 data. 72% average decrease in IPSS score. So those are our gray lines here. Green lines are post-treatment. 87% of those patients remained off of their medications. So at Austin Urology Institute, conversion to surgery is 49%. National average is 1 to 3%. 87% remaining off medications. So expanding your impact as an APP, hey, as an APP, you have skills. You have things that you can offer these patients. So the biggest thing that I could tell y'all to do is see a cystoscopy, see a transrectal ultrasound, get into the actual operating room and see an aquablation surgery. Educate the entire office on aquablation. This has been really, really impactful for our clinic. So you need your receptionists, you need your medical assistants, you need your surgical schedulers, you need your managers to know what aquablation is and at least be able to speak to it. I'd say at least 30% of what the whole entirety of the procedure is. So one thing that we do is every quarter we do lunch and learn. So I will put on a lunch and learn for our practice. Now I know all practices are different sizes. Ours is a pretty small practice, so we have about 12 employees. But I will do an education seminar on overactive bladder, over BPH, over kidney stones, over prostate cancer, and we get them educated. The most interesting and heartwarming effect that I'll see is I'll see my medical assistant and they'll pull a 300 PVR and they come to me and they're like, uh-oh, this guy's in trouble. We need to make sure and have an IPSS score. And in fact, even the better part is when they have post-op aqua and their PVR is 0 and they come to me and they see that, oh, this is why we're doing this for this patient. Meet with your surgeon and discuss their patient care pathway goals. Talk to your surgeon. Do they want you doing diagnostic cystotrusses? Do they want you to kind of enhance their BPH care pathway? Do they want you to do all these things? Having an open dialogue with these surgeons are paramount. Evaluate your patient education process. This is the most important. If you can get anything out of this webinar, talk to your patients about side effects of medications and talk to them about bladder health. It is so important. It is so sad to see when I do these cystoscopies on patients that have been on dual med management for years and years and years, and I scope them and I see a grade 3 trabeculated bladder with very high PVRs, and they know that they're in trouble. So this was a Yelp review. It's very small. I don't know if I can even read it, but I'll read the very bottom portion of it. I'm sure that y'all can freeze it and read it whenever y'all have time. The Urology Institute run by Dr. Shaw is top-notch and highly, highly recommended. I thank God for guiding me to the right urologist. God will most certainly bless the Urology Institute and everyone that works there. Basically, had a very enlarged prostate that was causing some impact to his sciatic nerve, and he was no longer able to drive. And we did aquablation on him, and he was basically, the sciatic nerve issue went away. He started driving, and all of his urinary symptoms went away. And it was a very, very nice thing for him to say. I do have one-on-one calls, so if you are in urology and you have a Procept rep and you want to get more involved with this, get in touch with them. My name is Alex Hughes. They can get in touch with me and we can have one-on-ones and we can walk through all of this in detail. Thank y'all so much for listening. I really, really appreciate it. Y'all can tell I'm very passionate about BPH. We have a surgery out here that has been doing wonders for our patients. And if you ever need anything, reach out to us. We're always here to help. Thank you.